Hello everyone and welcome to the audience and our panel members today, and thank you for joining us for the evolution of healthcare in the wake of COVID-19, looking at pathology, primary care and ICU perspectives. My name is Dia and
I'm Tom.
And we will be your moderators for today. So Tom's just going to talk a little bit about the session now.
COVID-19 has caused healthcare systems around the globe to dramatically rethink the ways in which they deliver care. Many ICUs have had to expand an order of magnitude beyond their usual capacity. Outpatient appointments have been delayed, and telemedicine is finally seeing widespread adoption. Research labs have halted work to lend resources to clinical labs, which have seen unprecedented demand for testing. And so on this panel, Dr. Matt Morgan, Dr. Tejas Suri, Professor Joe Martin, and Dr. Dipesh Gopal come together to discuss how health services have coped and will manage in the long term and the immediate future.
So before we start the discussion today, I just want to quickly go through how the session is going to work. Essentially, we're going to ask our speakers to briefly introduce themselves in a second, and then we will open questions to each speaker, but we encourage all speakers to give their input in every question, and we hope to have a great discussion today. So without further ado, we would like to ask speakers to introduce themselves and a little bit about today's session. So if we could start with Professor Martin today.
Super, hello and good afternoon from England. I'm Joe Martin. I'm Professor of Pathology at Queen Mary University. I'm a consultant histopathologist and I'm President of the Royal College of Pathologists, which has seen a very busy COVID.
Thank you very much. If we could move on to Dr. Suri.
Hi, I'm Tejas Suri. I'm a senior resident in Department of Pulmonary Critical Care and Sleep Medicine at AIIMS, New Delhi from India. And I'm happy to be part of the panel and sharing the experiences from India with all of you.
Thank you very much, Dr. Suri. If we can move to Dr. Morgan now.
Hi everybody, my name is Matt Morgan. I'm an intensive care doctor coming to you today from sunny but windy Cardiff in Wales in the UK. I divide my time between clinical work in the intensive care unit, research work in critical care and writing books.
Excellent. And last but not least, Dr. Gopal, would you say a few words about yourself?
Sure. Good afternoon, everyone. My name's Dipesh. I'm a GP who qualified last year, and I'm a researcher in the primary care department. My research interest is cancer care. I work at the same university as Professor Martin at Queen Mary in East London, and it's an absolute pleasure to be here talking to you today.
Perfect. So let's move straight on to our first question. So as Tom mentioned before, during COVID in England and around the world, we've definitely seen a spike in telemedicine and the lack of face-to-face consultations in patients. And we do know that patient relationship is a key part of primary care. So Dr. Gopal, if we can start with you with the first question about how telemedicine has dramatically increased in primary care during COVID, and how you think the lack of face-to-face contact affects patient satisfaction and patient relationship.
Thank you. Very good question. I guess when we talk about patient satisfaction, the changes that happened during the pandemic were just thrust upon healthcare services and people all around the world. So there wasn't very much time for people to adapt to new ways of consulting. So we already had remote consulting in general practice. So we already had lots of telephone consultations. Sometimes patients could book directly, so they could come to the front desk and book their appointment, but then that had to be stopped. So there was a lot more telephone consulting. I think a lot of patients perhaps felt that it was less reassuring to have only a telephone consultation, when I think a lot of the clinicians were more than happy to be reassured clinically that telephone consultation was an appropriate outcome. In some ways, I think it has been good, and it's improved some patient satisfaction in a way that there has been less treatment burden. So patients are having to like queue up for an appointment and then park their car and then wait in the consulting room. And it's been a lot more convenient for a lot of people who are tech literate. A lot of private companies had used video consulting a lot, and that wasn't available on the NHS. And then somehow, within weeks, we were using it quite a lot of the time. I think it's not been satisfactory for a lot of patients who were already isolated. So the most elderly who might not be tech literate, and people who thought English isn't their first language, people with severe mental health problems. But we have tried to adapt, I think, our approach by using interpreters and using other services to help us with complex needs. I think a lot of patients, I think it has been seen not only in primary care, a lot of patients have not felt that it's been safe to attend, even though we have felt that it has been. There have been clear precautions. The waiting room's definitely not that congested as before. We were cleaning very, very regularly between patients many times a day. And I suppose that probably does affect patient satisfaction.
Thank you. Do any of the other panelists want to add anything on this question?
So can I add, so we have a lot of hemato-oncologists in our college and immunologists, and agree with Dr. Gopal completely. A lot of patients have been very worried about coming into a hospital or a healthcare setting because they were aware that there was transmission between patients in that setting. There was a lot on the news about that as well. So for some patients, as you say, very reassuring. Telemedicine's happened much more broadly as well. So professionals are teleconferencing between themselves. We've been doing multidisciplinary team meetings and virtual MDTs. That's actually stopped transmission between healthcare members as well. So big changes. Telemedicine also in some of the digital pathology. So we've accelerated some of the program. We haven't got that nationally yet, but we can refer stuff digitally between each other. So this acceleration of telemedicine, linking up all the labs. We've now got an NHS where all our labs are connected by NPEX, which is a digital transfer of information, which was not present before the epidemic. So this rapid leap into telemedicine more broadly has been quite a transformation over such a short period. Primary care have been fantastic in this.
One slightly different perspective from intensive care, I guess, in that the face-to-face contact with patients, of course, is the same. It isn't an option in many cases to provide telemedicine when people are critically ill, although actually face-to-face has gone down because many of our patients are lying prone, lying on their front. But what it has meant, of course, is massive changes to family communication. And certainly when people are critically ill, the family and friends and other surrogate people who can tell us about wishes of patients play such an integral part. And the truth is, we don't know what that's done for the satisfaction and that interaction because we haven't yet asked them. And I think that is one aspect that this will do, is hopefully spur people on to find out. Because in many ways, the convenience and the ability to ask difficult questions to the right people at relatively short notice without the complexity of organising consultant meetings and group meetings may, for some, be an advantage. Of course, it may be a disadvantage, but I think the important thing is we need to ask.
Excellent. Thank you very much. Dr. Suraj,
Yeah. So from what we can understand right now, it seems like telemedicine is here to stay and it's going to grow even after the pandemic. So we have an long-standing experience of physical examination. Even with modern diagnostic technologies, physical examination remains a part of inpatient consultation. And this is the element which is completely eliminated from telemedicine. So I feel that going forward, we need the research area to be how we can replace bedside tests in the context of telemedicine and really have remote monitoring devices, remotely capture physiological variables and examination findings, and that would be the way forward.
Dr. Gopal, did you have something to add?
Hi, yeah, I was going to sort of reply to Dr. Siri's point. I mean, he mentioned about remote monitoring, and I think some of the GPs have tried to use some quite radical things about putting monitoring devices, even a digital stethoscope, in a room with like a webcam, and actually the GP not actually being in the room. So it's almost like a semi-sterile procedure in a way, and they're putting sort of stethoscope, telling the patient, here's stethoscope, put it there, and then they can actually listen in the other room. But I mean, it's not going to be a replacement. I mean, one of the best things about medicine is being able to treat and heal people. Why, you know, human touch is just so important. So it's one of the things we might have to embrace, but it's just probably slightly sad. But we have to move forward, I guess. We're going to sort of mitigate the effects of the pandemic.
Right, so we're going to move on to the next question. So, Tom, if you want to.
Yeah, so this question's addressed mostly towards Dr. Morgan. So you recently wrote a piece in the BMJ talking about the need for bold decisions, of which I think we've seen plenty in COVID from ideas like the Nightingale and early on people suggesting ways to split ventilators and stuff like that. So I think probably maybe a mix of good and bad bold decisions in some cases. But I was wondering if you might be able to talk a little more about that and kind of limitations of providing ICU care outside an ICU with ICU doctors.
Yeah, well, the first thing to say, the piece was actually based on an amazing song by a protest singer called Phil Oakes. So if anybody's bored tonight, in fact, there's a live concert of somebody who's just released a cover of his album. The song is called Days of Decisions, an amazing song to listen to. And the point of that BMJ piece really was to say that during these pandemic times, a lot of the challenges we've had in critical care haven't actually been challenges in medicine. They've been challenges of things like communication, tracking of patients. How on earth do you keep track of 200 patients going through a hospital, moving multiple times? How do you communicate between red COVID zones and a team of 200 nurses? And the piece really called on thinking about things like using the best other industry solutions, such as why aren't we using air traffic controllers to help navigate patients through a complex system? Why aren't we asking institutions like even McDonald's, who is amazing at producing very structured, efficient training for large numbers of staff at low cost at short notice? Why aren't we asking these people for advice? I guess in terms of providing ICU outside of the ICU, the truth is that happens every day anyway, be it in primary care, where you're looking after a critically ill patient, be it in theatres, the role that anaesthetists do, be it in ED or on the wards. So people do manage critically ill people all the time outside of ICU. And I think early on in the pandemic, the focus really was on the shiny bits of equipment, the expensive ventilators. We need to get people to be producing them. And of course, like most things in medicine, the things which make a big difference are not those shiny bits of equipment. They are systems of thought, and they are people. They are staff. They are skilled staff. And so when now we look back and think, how do we provide care to the most critically ill outside of the intensive care unit? what that really depends on are not ventilators and expensive drugs. It's those systems of thought, and it's having those staff and that training in place.
Yeah, that's brilliant. I mean, yeah, it's a fantastic piece, I think, and I think that's very insightful. Joe, do you want to add something?
Yeah, I mean it's a super piece, and I'll definitely go and listen to the song with Days of Decision. It's interesting what drives some of those decisions, and I think during this pandemic particularly, it's been driven by fear. So, including in some of the decision-making areas, it's fear of what happened in Italy. So a lot of the ventilator worries, the focus was on, don't run out of ventilators. And during a major incident, you focus on what you can do. Now, hopefully you're structured beforehand so that everybody knows what they're doing. But this particular virus is we're learning about it on the go. We would like to see a little bit of a stop and think and reinstate some of those systems of thinking that you very, very sensibly advocate, to have a think about, what are we doing? What are we doing next? We've got a very brief pause in the UK at the moment. I know that in India, in other areas, it's different. We're at different stages of the pandemic. So there is a point at the moment to stop, have a think, look at what we're doing critically. What do we need to do more of? What do we need to do less of? Have we got enough shiny things? Probably. And what are we going to do with a whole workforce who, quite frankly, is pretty exhausted at the moment? We've all been burning the candle at, both ends and the middle at the moment. And if we have a second wave in the UK, or if we need to build up more capacity for flu, that systems thinking has got to include also what's next. Flu vaccination, heavens, boy, do we need that before we go into winter. We don't want flu and COVID, trust me, that's not a good thing. So agree entirely, Matt, very, very strongly.
Excellent. So, we spoke about, how bold decisions that have had to be made. And so I want to direct this next question to Dr. Suri. So as we know, and as Professor Martin just said, the pandemic is in different stages around the world, and the response that everyone's having around the world greatly differs from one country to another. But however, having a large population and also having areas with high population density comes with its own difficulties of controlling a pandemic. And so, Dr. Suri, we want to hear about what it's like, what the COVID experience has been like in India, what bold decision and what innovative decision have had to be made, and how this will affect future healthcare in India.
Okay, thank you. So basically, India is a very large country and has a complex geography. So it's actually, the different states of India can be considered like different countries in Europe. So the pandemic is actually at a different stage in different parts of the country. And some parts of the country so far have been lucky enough to have escaped to a large extent, but some other parts of the country have been badly hit, and that is especially the population centers like New Delhi and Mumbai and Chennai. And so the thing is that India still now has adopted more of a cluster-based approach to the control, wherein we have identified the parts of the country which have more of the cases. After an initial nationwide lockdown, which was held in month of April, now we have gradually started opening up and focusing on actually the parts of the country which are having high caseload. So I think one of the advantages that India got while managing it people thought it would be very bad. It is of course bad, but I think India has done well in one regard, that because of the time lag, because the pandemic has struck India late, so we have been able to actually learn from a lot of global experiences, and a lot of the innovations which have occurred outside, we have adopted some of the best ones, and we have come up with a few of our own as well. And for instance, we heard about drive-through testing from South Korea, and it has happened in few parts of the country, especially in Delhi and places where the cases are more. Similarly, there has been contact tracing apps which people have used. Of course, there are concerns, but people have used, and they have been used widely. And then, of course, the health system of India, we have basically had a COVID care center, COVID health center, and COVID dedicated COVID hospitals. So we have actually tiered the health system into primary care, secondary care, and tertiary care, and actually have a centralized system through which, like Italy also talked about having centralized systems with different hospitals being part of a network. So the government has a central system through which they can allocate patients to different hospitals as per their geography. So I think in terms of the public health and the clinical management, there have been adoption of good innovations from different parts of the world. And then, of course, we are playing to our strengths. So we have good manpower. So we have contact tracing, and then we are using our strengths like the railways. Now we are talking about having dedicated carriages which can actually supply healthcare to remote parts of the country. So I would say that pandemic is still in its early days in India, and we are taking a stepwise approach, and we are coming up with new innovations as it goes along. Thank you.
Excellent. Thank you very much for your insight. Now, Tom, do you want to take it with the next question?
Yes. So this question addressed primarily towards Professor Martin. So obviously, antibody testing has been a very politicized thing, which I suppose is always interesting when public health meets politics in that way. And I was wondering if you could talk a little bit about antibody testing and what we do with antibody tests that are positive, who we should be testing, and yeah.
Okay, fine. So testing in general, I think, has been pretty politicized all over. Antibody testing in particular, it's been very interesting. Staff really want it. They know that officially it doesn't indicate immunity. Currently, globally, there's no confirmed evidence of somebody getting COVID twice. There's been some apparent recrudescence of infection, but there's no confirmation that you can actually get it twice. With similar coronavirus, we know that some of the immunity can be short-lived, and we're not yet far enough into this, particularly with the data, to know how long any potential immunity lasts. One of the concerns about saying, yes, if you're positive for an antibody, you're immune, is that early on, you actually can see a rise in antibodies within the first couple of days. And so it is possible that you can be antibody positive and virus positive. And we don't know whether it's potential. You can still be infectious if you're antibody positive and virus positive. So that's one unknown. The second big sort of area about this was, if you know that you're antibody positive, are you going to go out and, behave differently? Are you not going to put on your PPE? Are you not going to obey social distancing because you're immune? And so again, can you still transmit it if you're immune, but you've got virus on you or you've got virus about you? Are you going to behave differently? So that's where the real tensions arisen. So I wanted to know whether I'd got antibodies. I don't. It's been offered to staff throughout the health service and social care and primary care. And a lot of patients want to know. They think they've had COVID and a lot of testing wasn't available at the beginning. And so they want to know that. The third and big area around antibody testing is, can you use it for passporting? So big, can you, if you're immune, can you do stuff that can help open up the economy? And opening up the economy is a real issue. We know very well poverty, poor economic circumstance breeds bad health. I work in East London. Whitechapel's a very, very poor area. We've got high levels of child poverty, some of the highest levels of child poverty in Tower Hamlets in the country. And it's, we know one of the reasons I work there is every pound we bring into research, every pound we bring into healthcare industry, healthcare research there, indirectly knocks onto the healthcare of our community. So making sure that opening things up has been a big push. It's always it's a balance of risks, and the government, us, everybody, the world is criticising everybody else about some of these decisions. Everybody's making judgments as to where their particular risk boundaries sit. And antibody testing is one of those things that we are learning more about. And that's the final point. By rolling out serology testing, we've learnt an enormous amount. So Dr. Suri mentioned about high incidence and low incidence areas. We know that in London, younger people have got about a 27% antibody positive rate. Older people, it's lower. But that was quite a surprise. And that's probably, again, asymptomatic. It helps inform our knowledge of asymptomatic transmission in the community and previous prevalence also.
I think it's that fascinating collision as well between humanity and science, I guess, in a way. We're all scientists and doctors, but we're also, I'm a dad, I'm a husband, I'm a son, and I think the antibody story is kind of the ultimate way of making sense of a story in many ways, and we all want to make sense of our own story. 80% of my colleagues in intensive care had coronavirus, and that was really tough for staffing and well-being. I haven't had any symptoms, so how do I make sense of that story? Even if the antibodies don't change things, well, that kind of helps me as a human make sense of the story. And I think through this pandemic, we've almost been through this amazing insight of behavioral medicine. Amos Tversky and Danny Kahneman won the Nobel Prize for behavioral economics, of what happens when people know the logical answer in economics, but they are human and they may behave differently. Well, I think this is the ultimate test of behavioral science in many ways, and it's fascinating and complex.
Yeah.
I was going to say, I think it's very interesting about getting tested, and I think, as Joe said, that so many healthcare staff were really keen to really find out what their status was, and similarly to what Dr. Morgan also said about making sense of the story. I mean, for me, it's very much what Dr. Morgan said about I was so worried about getting tested because I felt that in some way my subconscious mind would cut corners in like donning PPE, taking it off, not washing my hands, wearing face covering in public settings. I was just so worried. So I thought, I better not know actually, because I thought I might have had it. But then the risks of finding out that you had a positive or negative antibody test would have been nice for reassurance. But I just thought, you know what, best for me not to know, because I can't control this one. But interesting.
Yes, I also agree with what Professor Martin and the others said, that it really, to some of us, it really does allay a fear that yes, we have gone through this and we have had COVID, even if we were not symptomatic or we had mild symptoms, we do feel a bit reassured. But again, we need to hold our horses, and we don't know if there is a reinfection. And also, one thing which concerns me here is that there are increasing reports that people who have mild infections have lower titers, and the titers disappear very quickly. So I think this is an area which we should keep looking for.
Yeah, completely. It's a series of evolving natural experiments, both in as Matt says and as Tejas says, both in the behavioural side. With Dipesh, do you worry more about you'll behave differently if you've got antibodies, or do you worry more about getting it? Are you less worried about getting it if you're antibody positive? You probably are. It's a very complicated, and it's much more particularly for healthcare staff. I think it's much more conscious, and with so much media coverage about infection as well, it's really worrying for patients. And as Matt says, making sense of that story, antibody testing may be, at this stage, one part of that, but it's certainly not the whole answer. So keep washing your hands.
Thank you for that. We're just coming up to the end of the session, but we wanted to quickly finish off with one last question that we would like to open up to everyone, and that is, how do you think the next pandemic will be different, and what we've learned from this pandemic?
I'll start at the 10. So I've been involved with massive numbers of major incidents over the years, because I'm old, and the healthcare system has major incidents. We have nasty big scale traumas, we've had bombings. Every incident is different, and the big lesson from this particular pandemic is that it's not flu. Our flu plans don't work. Dealing with it as if it's a flu, a big nasty endemic flu, it doesn't work. The virus has thrown us lots of different curveballs on this one. And I think what we've learned to mobilise, we've learned to use the tech, we've learned to work together across disciplines in a brilliant way. But I think we'll still have to be very nimble with the next one. I think it'll be different. Be different in ways that we won't understand. We may deal with uncertainty a little bit better. We might have health observatories that can bring in data quicker, faster, evidence-based centres which can help us have a visible and current. We might be quicker to stand up some of those areas that help us know how uncertain we are in particular areas. Our pathologists have been amazing, and they will continue to be amazing throughout whatever next epidemic it is.
Hi. Professor Martin focused on the differences in the current pandemic from the previous pandemics. I would take a different approach and focus on actually the similarities. If we go through all the epidemics and pandemics which have happened, including Zika, Ebola, SARS, MERS, flu, and even HIV, we see mostly all of them are zoonotic, mostly all of them are RNA viruses. So what I feel is that we are going to face even more frequent pandemics now in the 21st century. We've had MERS, SARS, Ebola, Zika, and it's just going to happen much more frequently now. So I think what we need to think about is the One Health concept, where animals, environment, and human beings are part of, and we have to see whether human activities are actually increasing the risk of these pandemics. And secondly, I would say that because most of these are RNA viruses, like a revolutionary discovery was the discovery of antibiotics, which usually have broad spectrum against bacteria. So we really need to work on our platforms for antivirals against RNA viruses as a whole, and vaccines against RNA viruses, platforms which can help us in developing vaccines within weeks, not months. And that would be something which would really, something we should prioritize going ahead.
I was going to say, I was going to, again, take a completely slightly different approach, I think, to Tejas and Joe. And because I think from my perspective, in some ways, it has made people, I think and stop and think, because it's had such a huge impact on everyone, really. And if we look at sort of, there's been such an economic impact this time, and after quite a lot of big economic downturns, some good things have arisen from the ashes. And if we look at sort of in the UK, we had the birth of the NHS came after the Second World War, and it was revolutionary idea. And in some ways, what Tejas said about the alluded to almost the economic and the political systems, and are we doing things the right way, perhaps as a society, and hopefully we will be able to probably stop and think, and perhaps maybe we are going too fast as the human race. Basically, we're just moving too fast, and maybe we need to slow down, reflect, and take a bit more time on whether we're going in the right direction, more philosophically as a human race, but potentially as well.
I guess three brief points. Firstly, thank you for including the question which says, what will the next one be like? And that really just confirms that, look, there will be others. And, the certainties in life are death and taxes. Well, the certainty in human evolution has been further issues like further pandemics. So that's the first thing, is to be upfront and honest and say, look, we need to think and confront that. And of course, the mortality in this pandemic compared to others like Ebola and SARS is actually remarkably low. So, this may be a test run for one where the mortality is much higher. I guess the second thing to say, the NHS was mentioned, and I'm about 50 miles away from where Naira and Bevan, one of the people who first thought about National Health Service in the UK, was born. And he famously said, the purpose of power is to give it away. And I think although we've managed things as a global community in medicine, even intensive care is a small global community, the same as epidemiology and pathology and primary care. I think we've communicated with specialties very well. But I think the global political way that the pandemic has been managed, I think that needs to be a much more cohesive giving away that power, not only to the people, but to the politicians to talk together and work together on this. And I guess the final thing to say, one last quote, is medicine is the most scientific of the humanities, the most humane of the sciences. And I've mentioned human behavior. I think there's so much we can learn from science, be it dexamethasone or vaccines and RNA viruses or antibodies. But I think that human behavior aspect is absolutely key, and how people behave even when the science is known. And I hope, like the revolution in behavioral economics, that will help almost foster a new specialty of behavioral medicine almost, and how humans react to science and react to what is known. But the ultimate answer is, I don't know. And I think keeping asking questions is the best bit.
Perfect. Thank you for joining us. Tom, would you like to say a word?
Yeah, I mean, I think it's been absolutely brilliant. I think you've all raised a lot of points to think about, and I think it's obviously quite interesting to see how these common themes can kind of emerge from separate countries, separate specialties, and I think we could all what you've had to say.
Thank you again to all the speakers that came in today. I think that brings us to the end of today's session. I've really enjoyed hearing all of your points, and I'm sure all the audience have as well.